We'll switch gears a little bit here to discuss sodium fluoride, which I was happy to hear that you guys are doing as well. Sodium fluoride is an interesting problem. Well, let me get into this, and we'll discuss that a little bit. So, as some of you may know, sodium fluoride is a diagnostic molecular imaging agent used for the identification of new bone formation. So F18 is administered IV as sodium fluoride and was approved by the U.S. government Food and Drug Administration in 1972. And, I thought this interesting. And when I did my training, I was all excited. When I worked in Dallas, Texas, we were doing research on sodium fluoride indications before it was approved by our government. And I, called up the gentleman that trained me, who had been a technologist for 50 years, all excited. And he told me he was doing that 30 years ago. And I found that fascinating. Well, the problem in 1972 is there wasn't PET. So we were trying to collimate a high energy material with a gamma camera. And in 1972, the equipment just didn't work. It was just subpar. I tried to get some of those old pictures, but he had them on the old reels, and I just couldn't get it to where I could do it. So then it was discontinued in 1984. The FDA is underutilization, and this is when MDP came out. MDP came out and HDP came out and hit the scene, and then sodium fluoride just went away. So, as I said, in 1970, the equipment available just simply could not perform. It was very difficult. As with I-131, it's very challenging to collimate a high-energy material. You lose too many counts. Counting statistics go way down, and then therefore spatial resolution is horrible, and you need good spatial resolution here. So as PET-CT became more available, researchers throughout the world began trials. In the U.S. in 2008, the National Cancer Institute filed a new NDA, a new drug agreement with different potency and dose to the original NDA. The great thing about what they did was they're now able to basically take a byproduct and turn it into sodium fluoride. This makes it very cheap and very effective. In 2010, the U.S. government started a nationwide trial called the National Oncologic PET Registry, the goal of which was to get 30,000 patients in the U.S. So our government sponsored this trial to allow us to test out the NOPR, the National Oncologic PET Registry, on any cancer patient. Any patient with cancer that you suspect has bone metastasis, the federal government of the United States is paying for that patient's exam. What they ask us to do is we have to fill out a questionnaire, the doctor does ahead of time, with what they suspect. The reading doctor has to fill out a questionnaire on the day of the exam based on his or her reading findings. And then the ordering physician has to fill out another form saying how the sodium fluoride changed their management. This is how the U.S. government is moving towards new tracers. It's I think, a pretty good system. They say it allowed me to not order an MRI. It allowed me to not order a bone scan. It allowed me to biopsy. It changed chemotherapy. I moved to radiation therapy. It's questions like that allows the physician to say to the government, hey, I need this, it helped me. Hey, it didn't, it was a waste of my time. So sodium fluoride is a very simple material, and sodium fluoride, at least in the U.S., is inexpensive tracer to make. It costs about half the FTG for me. Often cyclotrons are able to make the NaF with leftover heavy fluorine. The prep for sodium fluoride bone scans really is non-existent. It's similar to a MDP bone scan, as you guys know. We do ask the patients to be hydrated. Same problem. This is radiation dose reduction. Bladder, once again, target organ. The dose for pediatrics should be weight-based. That is a key thing. We're basically 2.2 becquerels per kilogram. For us, 0.6. That makes it 0.5 to 5. We're normally right around 1 to 2 millicuries, somewhere right around that area. The great thing about this tracer is you need such a low dose, which I'm sure that you've seen. And the imaging can start at about 45 minutes, and everybody gets head to toes for this. So early data from the NOPR project, the National Oncologic PET Registry, showed that in more than 40% of the time, it changed the management of using sodium fluoride, and that is incredible. PET-CT and molecular imaging can have a test that once it's done changes what doctors do more than 40% of the time. That's just amazing. To be clear, of this project so far, slightly more than 70% of these patients were prostate cancer patients, and I'll explain why that's important in just a little bit. I think this is a really important slide, for people to understand, and what this means. Sodium fluoride and FDG are complementary, so that's an important point. As basically there are three types of bone lesions: sclerotic, blastic, and lytic. Each kind of cancer typically has different types of bone metastases. For example, prostate cancer, almost dominant blastic disease. Breast cancer can be mixed. It can have lytic and blastic disease. Lung cancer typically is only lytic disease. So as you're thinking about that, obviously sodium fluoride is going to be better on prostate cancer patients. Well then, lung cancer is more lytic. FDG is probably a little better. But I'll show you an example. If you take, it's important to understand, as I said, they're complementary. So we need to understand where the metastatic disease is likely to occur. So here's an example of what I'm talking about. So you take an advanced prostate cancer patient. So going left to right, this is an FDG PET scan. Okay, so you can see lymph nodes, you can see, this is a bad scan. You see lymph nodes in the retroperitoneal area, up in the supracloud, and this is sodium fluoride. So as you look at the both, you've got brain, this is how you always know FDG. You got brain activity, no brain. Sodium fluoride will not have anything but bone. You will have a little soft tissue sometimes just because there can be a little blood pool activity, things like that. But as you can see, if you look at think about a normal bone scan, how much clearer this is. And, this is actually blurred because it's pouring into the PowerPoint. But you can see each rib, each bone, each separation of the spine, hips. So then you go back and look. Well, if you look at the hips, activity, 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 no activity, activity, no activity. Activity in FDG, no activity in sodium fluoride. So in order to get a complete picture, we just add them together. We have a simple software package. The doctors want to know every cancer they can see. And then we just add them together. Simple. Then, this is easy in prostate cancer. When you get to breast cancer, you have a whole other problem. We'll get to that in a minute. So it's important for us to ask if better image quality actually changes management in patients. U.S. government now requires this thought. In order for our government plans to cover a new exam, it has to change management. What is the point in seeing, if on an MDP bone scan you see 5 lesions, on a sodium fluoride bone scan you see 500 lesions? If nothing is changed by knowing more cancer, what's the point? If it doesn't change what we're doing, there's no point in knowing of the extra cancer. It's not going to change radiation therapy planning. They're still going to get chemotherapy. So it doesn't change anything. But an important change and update happened. NCCN guidelines are something that's, I'm not sure if you guys utilize this, but basically what this means, this is evidence-based medicine practice guidelines by cancer. It's utilized in the United States a lot. It's a free online government-sponsored program. You can look at a specific type of cancer and stage and be able to say what the evidence says you should do. So in 2013, they changed that a single metastatic lesion detected, that evidence now says that you should do external beam radiation and not chemotherapy. Well, that's a big change. So, now we must determine what all those inconclusive areas on an NDP bone scan is. Because as you all have seen, if you do a planar bone scan on a patient with metastatic disease, you can see degenerative changes. You can see, patchy uptakes. You can see all kinds of problems. You don't have very good spatial resolution, even if you are very close. Even if you do a great quality exam, it's challenging. So that's where sodium fluoride excels. We go from looking at 2D to 3D with the CT component or without. You will see very famous institutions, for example, Johns Hopkins. A lot of times these patients don't do a CT scan. They don't feel like they need it. They can see adequate spatial resolution and image quality without exposing the patient to CT. So this also helps to determine abnormal accumulation, for example, as I said, DJD. Now the doctors are so good at this, they can look at the CT and see where the area of sodium fluoride is and then confidently say that's degenerative disc disease or DJD or just changes, even fracture, facet disease, arthritis, things like that. The sodium fluoride is such a potent imaging agent. The count rate is so much higher. You just get such better quality. So I threw this slide up there just to show some of the differences. MDP, sodium fluoride. MDP doesn't really go into the red blood cells. Sodium fluoride can. Protein binding in MDP is a lot higher. In sodium fluoride, it's less. First pass in MDP is a lot less than sodium fluoride. Also, one of the reasons we wanted to talk about three-phase sodium fluoride imaging in our diabetic feet. It's similar renal excretion, both goes through the bladder. So basically, sodium fluoride is cleared quickly, and with the imaging characteristics of PET, the count rate will be 1,000-fold higher. As we talked about 10 to 100, in our experience, the uncollimated sodium fluoride imaging compared to MDP, when you have the delays, sodium fluoride is a lot higher. This allows excellent counting statistics and the image and increased image quality, with the PET able to obtain an uncollimated image. So another advantage. One major advantage over sodium fluoride is NDP, as Georgia was talking about, treatment planning. You're now able to do a 3D simulation based on sodium fluoride. MDP is planar imaging, and even with SPECT-CT, you can't put them in treatment planning position for a SPECT-CT, and it's too long. Sodium fluoride can easily be added directly into the treatment planning system. This allows the doctor to palliate pain more effectively. It allows us to expand the role of treatment planning because there have been numerous statistics of treatment planning changes changes the planning so often, and especially between the radiation oncologists themselves. If you go from one to the next, if the addition of treatment planning helps the patients get the best system available. So, important point though, radiation dose. We are now not at 10, we're at probably 5, so this is somewhat. And I can tell you, some of these larger patients, 25 millicuries is a pretty big dose of MDP, and the doctors often want more. The prostate cancer patients, MDP struggles in the pelvis. As we talked about, lesions close to the skin, that's not what we're talking about in bone scanning. As you know, the spine is deep, the pelvis is deep, and bone scanning can be very inaccurate in the pelvis. Well, it's not just this and this though. You have to remember about CT part too. So a standard sodium fluoride is about 3 to 4 times more radiation exposure than MDP. That's why we have to figure out if we're going to expose these patients more, what are we getting, why do we need it, and what are we going to do with it? That is the important point. Because these are patients that are going to live a long time. Prostate cancer patients live with these diseases longer. So I'll go back to ILIKE case study. So, an 84-year-old man with prostate cancer presents for a workup after his PSA had jumped to 22 and back pain. So the workup included an FDG PET, sodium fluoride, and a bone scan in this patient. This was in our early days of doing this. So showing this, basically you can look, this MDP is not totally normal. You can see this, bone blasting. Now, according to a recent literature, 60 to 75% accurate for MDP bone scan planar imaging. Well, PET-CT, nothing. Completely normal PET-CT. Sodium fluoride, you also then pick up this lesion, this lesion, this lesion, this lesion, and this lesion. So this is an example that we searched for a long time of before 2013, this patient would only have external beam radiation, period. Nothing else. Using sodium fluoride in this patient excludes him. Now they would probably do it if this was horribly painful in this patient, but this will move this patient on to other disease treatments. For us, that would mean moving on to radium-223 or Xofigo. So the MDP and the FDG underestimated this disease. According to new guidelines, as we talked about, the treatment option for this patient went from IMRT to a new molecular therapy for the treatment called Xofigo, radium-223. And I'm not sure that you guys are doing that yet, but basically this is an alpha emitter. It's very good treatment. It causes double DNA breaks. We've done numerous patients with this now. It's very well tolerated. We'll talk just a little bit more about that. But understanding the disease process can help us to provide the best image possible. I'll show you another example. This is a little older publication, but I think it's interesting to show this. Now, this is lung cancer. 52 patients, 13 had bone mets, so the sensitivity of planar bone scanning is 54%. Now, as we talked about earlier, lung cancer is dominantly lytic disease. MDP bone scanning will have struggle in lytic disease. MDP bone scanning is best for blastic, bone remodeling process, not lytic disease. So adding SPECT to these patients dramatically increased their disease, the detection of disease. Going from 54 to 92% and 100% specificity is incredible, but it's very challenging. Where do you SPECT? Do you expect, the top? Do you expect the bottom? Do you do both? And then if you do both, well, you just added an hour of imaging for the patient. And, very few patients can tolerate, once you've done 30 minutes of planar imaging and then you do another hour of SPECT imaging, that's very challenging for a patient to tolerate. Well, sodium fluoride for this patient was still 100 and 100, even though I said they struggle in lung cancer. So, lung cancer, as we talked about, is lytic disease. Therefore, you can better evaluate by FDG. So similar date and time, switch it over to prostate cancer. Planar bone scanning did a little better. That's because, as we talked about, prostate cancer is blastic. Lung cancer is lytic. It's understanding what type of lesions we're looking at are important. And similar with the SPECT, and then as you see, F18, still the sodium fluoride still did better. So, as we said again, blastic bony disease. This makes sodium fluoride and bone scanning more accurate in prostate cancer. So, just to put them together, just so you don't have to remember going back and forth, planar bone scanning, 54 and 70, and then sodium fluoride was 100% accurate. Example of how we use sodium fluoride in clinical practice. I'd like to show you one other case study. 83-year-old man with a history of prostate cancer presents to his urologist with hip pain and rising PSA. That's been an interesting thing in my facility, as now we used to only kind of educate medical oncologists, surgeons, and radiation oncologists in helping them order PET scans. Now we're finding that we're educating urologists. It's been an additional patient population for us to seek out. So, here's his sodium fluoride picture. As we said, this is prostate. He had seed implants, the rising PSA, and hip pain. As you can see, it's very easy to figure out through the side. These pictures I'm showing, that's just on my computer. Allows me to put it on the screen. But this is kind of an image. You can see bony disease all over this in this patient. So it was read, great addition to the imaging, the whole body looked for visceral metastases. Findings were worrisome for metastatic disease in this patient. And I'll show you one more example of how sodium fluoride can be used. A 60-year-old man, so this is a younger person with an aggressive prostate cancer, is referred for the evaluation of molecular therapy. So that means now we just get referrals for Xofigo. We get referrals for the alpha-emitting agent. Patient was on chemo, worsening with treatment, nearly intractable bone pain. Sodium fluoride was available for workup. So one good thing about this test is now we skip the CTs. We typically don't do them on the prostate cancer patient. So as you can review, unfortunately, this young man, he's got shoulder, back, he's in terrible pain. He had a hard time. This is a 1 minute per bed image, just so you know, on this patient. I actually helped my technologist. He was in such horrific pain. This is a 5-minute scan right here. And you can still see superior image quality. It allows us, he took as much morphine as he could, came in, got him through, and 5-minute image. We didn't do his legs on this patient, just to do the absolute best we could. He helped as still as he could, and still he could get fantastic image quality. Extensive, as the nuclear medicine physician read, extensive osteometastasis. Locations appear similar. He had a plain bone scan before, but unfortunately, problem with this patient, but the great thing about sodium fluoride, this is how we skip the CT now. You have a CT. So, for the treatment of Zofigo, you cannot have lymph nodes larger than 3 centimeters, or you cannot have liver or visceral disease. So this allows us to, as you can see, he has large lymph nodes in his pelvis. So instead of having him go through an extra CT scan, we use the CT scan that we have. So this means that this patient has to go back to chemotherapy or really radiation. So we're taking the molecular imaging test, not changing anything. This isn't increased KP, KVP, we didn't increase MAs. This is our standard, anatomic localization CT that goes along with the sodium fluoride. So in one exam, sodium fluoride showed extensive metastatic disease, bony disease, but also, unfortunately, extensive adenopathy, which did not allow us to give him radium-223. So this patient was then referred with palliation with samarium-153, to help him try and get rid of some of his intractable pain that, his Dilaudid and morphine just couldn't touch. Still, an interesting use of molecular imaging in this patient. So as I said, the sodium fluoride allows us to show bony disease and very good accuracy. So we have found that, and originally we thought that we might be able to see how well treatments are working, chemotherapy and the such, with sodium fluoride. Initially, we tried to perform sodium fluoride scans to see if treatment was working, but found that similar phenomenon to MDP, you get flare phenomenon. You simply cannot tell the difference between healing bone and cancer. You just can't tell. And other thing, as you notice, induced sodium fluoride, the SUV, which you can use in MDP, is completely meaningless. It doesn't. The unit means nothing. There's not an algorithm in place to figure out how the sodium fluoride works in the bones. However, we did notice, though, that you can easily tell disease progression. New metastatic deposits can accurately be identified using this technique. So you can't tell, which in PET, you can see if the SUV is going down. You can't do that, but you can easily identify new metastatic deposits. And that's what I have. Thank you.